CoveCoffee.com. It is Coffee Talk with Jay Fox, brought to you in part by the Cove Coffee Shop and the brand new Cove Pizza Shop in downtown Ontario. And as we do every week, we have another exciting guest. Today, we are speaking with Dr. Johanna Wilson, who is a board-certified psychiatrist with more than 10 years of experience. Dr. Wilson, welcome in. How are you?
I'm great. Thank you for having me.
It is our pleasure. I would imagine that you are overwhelmed with people who need your services at this time.
We are very, very busy. Yes.
I do a lot of work with the Know It Before You Need It campaign and the Richland County Mental Health Board with Joe Trollian. And I get to see the statistics, and we have some issues in Richland County, and suicide and depression are among the top issues. In your opinion, do you feel that this is par for the course, or that this condition has been severely exacerbated by COVID?
Yeah, we're all kind of asking ourselves the same question. Since January 1, we've scheduled over 150 new patients in our office, which is definitely a record. And I'm so pleased that we're able to do so and to help the community members. But, people will say, well, that means business is good. But at the same time, that means a lot of people are suffering. Right. And I definitely think that COVID has had an impact, especially on our younger population, kiddos, teenagers. This is kind of the first big thing that they've been through, a lot of our younger population.
For those in the audience who might not understand the difference, how does one know whether they need to go to a psychologist or a psychiatrist?
Sure, that's a great question. So a psychiatrist is a physician, a person who went to medical school, learned how to prescribe medication, had to go through all of the same rotations in medical school that the rest of the doctors did, obstetrics and gynecology, cardiology, ER, surgery. Psychologists kind of go into their training with the specific goal of some of them do research and some of them do clinical. So from a clinical perspective, psychologists will do primarily kind of therapy, counseling services, but they can also do a number of testing services as well, kind of determining if there's any learning disabilities or cognitive dysfunctions, things like that. But psychiatrists primarily prescribe medications and do some therapy in addition.
So here's the million-dollar question. How do you know what medication to prescribe?
That is a great question. So really the medications fall into general classes of what we call antidepressants. And a lot of people will come to see me because of anxiety, but there's antidepressants, antipsychotics, mood stabilizers, those kinds of things. So primarily what we do is we do a full diagnostic assessment to determine what's really going on with the person, what's the underlying illness. Because I think one of the misnomers about mental health is that that it falls somewhere outside of medicine, that this is maybe some type of coping flaw or what have you, but really it's a brain illness. It's, the brain is the last frontier that we have not yet figured out. And so once we kind of come up with a complete diagnostic assessment and determine what is the illness that the person is going through, are they suffering from OCD? Are they suffering from bipolar disorder? Is this unipolar depression? Then we go through and think about, okay, so from the list of the different illnesses that they're suffering from, what medications has been studied and approved by the FDA to treat those illnesses, and at what doses? What's the goal? What are we trying to get to? What kind of reduction of symptoms are we trying to get to? What type of quality of life are we trying to improve?
One of the things that we're trying to do with Know It Before You Need It is to get people to start having the conversation so that we can address the matter and get people the help that they need. Why do you think that there's still a common misperception that when somebody says they're depressed, people think, well, they're just kind of bummed out? Mm-hmm. Because that is not the clinical definition of depression.
Right. Yeah. It's interesting to me. I'll give you an example. Recently, I was talking with a family member of mine who I was showing some videos about a new treatment procedure that we have in office, and showing her about what the brain looks like, a depressed brain looks like, and how we can actually see on functional MRIs that the depressed brain actually metabolizes nutrients differently, and we can actually see it that it's not functioning very well. And she looked at me and said, "So it's actually a brain condition?" It's like, yeah, it really is. We don't think about it that way because it's not something that we can measure in a person's blood. We can't get a value from their blood to show us, oh, that this level looks off or this or that. It falls much more in that gray zone of medicine, of kind of putting together a set of symptoms that we know are consistently associated with different illnesses, putting those symptoms together and kind of saying, okay, this most appropriately fits with depression, as opposed to, bipolar disorder or what have you. And it's not a matter of weakness, but I do think that the environment, circumstances, stressors all play a role on mental health. And so I think sometimes people will think that it's primarily those external stressors that must be causing a person to feel that way, but they're just a part of it.
So when we think about the brain as a living organism, we're dealing with chemistry, we're dealing with nerves and some form of electricity, to use layman's terms.
Right.
We're dealing with water. There's a variety of different things that go into what makes up the brain and its functionality. How do you know whether the issue is chemical or nerve related? What are some of the telltale signs that help direct you down the right path?
Right. So like I said before, the brain being the last frontier, we actually don't know a lot about the brain. We kind of have stumbled upon some of the medications that we know help by chance. Some of the things that we utilize over time were actually directed at treating other medical conditions, and they had found along the way that those medicines would help. So really, it's a combination of all of it. Right now, the medications that we use assume that the brain is a chemical being, because that's what we have to work with. Kind of like the rest of medicine, we have medicines that treat based on changing the chemistry. Now, in other parts of medicine, in cardiology, they have electric abilities to be able to kind of change the way the heart conducts. So there is no one or the other. It's really a full mix that we don't yet really understand.
Many years ago, we heard stories about things like shock therapy, where there was actually electricity that was, pulsed into the brain. From a layman's perspective, that to me sounds very dangerous. Why would we have ever done something like that?
Well, that's a great question. And in fact, we still use electroconvulsive therapy today. It's actually one of the most effective treatments that we have for treating depression, but it comes with risks. So what we have found by using ECT, as we call it, is that it's kind of a reset for the brain. So we administer an electric pulse to the brain, and it pushes the reset button. And so whatever abnormalities were happening chemically, neurochemically, electrically, it's thought to help everything start to function as it should again. And we do see that people with severe depression, who can even be catatonic, meaning that they're barely functioning, those people respond very well to ECT in getting them better within a matter of 2 to 4 weeks, which many people know that antidepressant medications can take 6 to 8 weeks and even longer, really, to feel where you need to feel. So sometimes when people are physically in danger from their mental health problems, ECT is a resort that we turn to. However,
so what are the risks, though?
Exactly. What are the risks? So anesthesia has to be administered at each electroconvulsive therapy session. And so anytime a person goes under anesthesia, there's risks, of course. There's cardiac risks, and people can suffer from headaches, nausea, anything that you could think of that could potentially come from a seizure. We do treat the person prior to the ECT treatment with a medication that makes the muscles go limp, so that the actual seizure itself doesn't cause a lot of muscle pain, but I still have a lot of patients that experience that. And even more so, I think what the studies have found is the cognitive effects that ECT can have on the brain. So some memory problems. Typically, it's mostly short term, but I do have some patients that have gone through ECT that can tell me, you know, they don't remember a whole lot around that 6 months to a year span during the time that they had treatment. And because of that, many of them, even though it may have helped save their life, they don't really want to go through that again.
Yeah, that makes a lot of sense.
Yeah.
Now, you are one of the first, if not the first, practicing physician to bring transcranial magnetic stimulation to our area. And while that's not electricity, it's magnetics, it still involves, you know, a pulsation of some sort. So tell me, how did you find this treatment modality and why did you decide to get behind it?
So this treatment modality actually was known to me in my last year of residency at the Ohio State University of Medicine. But
My alma mater.
yeah, yeah. But at that time, you know, we knew that it was effective, but insurance companies weren't getting behind it just yet. There weren't a lot of devices around to be utilized. And actually, TMS got its first FDA clearance in 2008. And it's taken about this long for insurance companies to kind of really get behind it and say, okay, we can see the effectiveness. We're going to pay for it for depression. And so I've been practicing in the Richland County area. It'll be 7 years in June. And I'm starting to get to that place with a lot of my patients where, you know, we've been through a lot of these medications. We've tried so many things. And I can't even, or I couldn't even bring up the idea of TMS because it's so far away. It's a time intensive treatment. And the closest locations that we had to us were an hour distance.
So I'm gonna let you ask the next question because I know we're thinking the same thing.
Yeah. So it was, how do we get it here? How do we
Right.
have our patients, be able to access this care? And, to be honest, if somebody else in the area had a TMS machine, I would just be referring to them. Let's just get these patients treated and get them well. But we don't have one. So I started doing some research and I really wanted to be behind the research and say, I know that this is an effective form of treatment. So spent the last 4 to 5 months really reading books and articles and everything that I could to say that I felt comfortable having my patients go through this form of treatment and bringing it to our community, which is exactly what I did. Kind of reached out to MagStim, which is the first, they're like the innovators of TMS. And so I felt comfortable with them being the device that I purchased from. And here we are. We started in March with our first patient and are quickly getting more referrals in and are very excited to have our patients not have to travel or not even have it as an option to them.
So you said earlier in the interview that you're able to actually map the brain and show areas that are poorly functioning. What does this stimulation do to those areas?
Right. So what they have found in research is that there's 2 forms of treatment that you can use with TMS. There's a low frequency and high frequency. Anything low frequency actually down regulates and kind of quiets that part of the brain. Anything higher frequency gets that part of the brain working better, increasing metabolism in that area. So what we have found in research is that the most effective forms of treatment are targeting an area of the brain that has a really long name on the left side that we treat with high intensity pulses of magnetism over a very short period of time. It's actually down to 3 minutes now. And that happens over the course of 6 weeks. And during that time, that part of the brain, we can actually, if we were to do functional MRI, we could see that part of the brain is now starting to work more normally. It's starting.
So it's almost like a massage for the brain.
Exactly.
Okay.
It gets the electric pulses going in that area.
All right. Now, we said that we don't know a lot about the brain and we don't know, I've seen maps of the brain and what they claim certain parts of the brain do. Mm-hmm. Are there any negative risks to stimulating a poorly functioning part of the brain in a situation like this?
So they have found that the side effects from TMS are extremely low, very minimal. And putting it in perspective, you get a tremendous amount more energy, magnetic energy from an MRI than you do from a TMS treatment. So the same kind of contraindications that there might be for somebody with an MRI, such as having any ferromagnetic implants in the brain or anywhere near there, would be a contraindication. That person would not be an eligible patient for TMS because that magnetic pulse could move that element. But beyond that, there is a reported increased risk of seizures in which a person who has a history of seizure disorder, we would think more cautiously about, are they an appropriate candidate? But much of the research says there really is such a negligible risk with seizures. But it's something as clinicians we should always think about, that we're not just this is a serious thing. We're treating the brain here and we have to be cautious. But the mapping has come so far. Our treatment magnet, the coil is called, will actually, when we're mapping, what we target is a twitch of the thumb. So when we put it on the patient's head, we target a twitch of their thumb, which we know is supposed to be in a general region. And then the area that we're looking to treat that is poorly functioning in the brain in depression is a certain specific number of centimeters away. And the device we purchased actually has a navigational system that has the ability to help us find and target that area precisely each time.
Now, do you continue therapy of medication concurrent with the transcranial magnetic stimulation, or does one stop the other?
So the studies initially were done on patients who were not on medication. And actually those studies found that 1 in 3 people found remission from depression with a TMS device, and that 2 of 3 were responders, meaning they had reduction in their depression scores. And those were on patients who failed 3 or more medication trials prior to that, but they were taken off medication and then treated with TMS. In the clinical world, we don't really do that because for the most part, many of our patients are partial responders. So many patients, even though they say that their medications aren't all that effective, they'd say, but I would hate to see what things are like without the medicine. You know, that they're at least keeping me functional, but I'm not anywhere near where I want to be.
So this is not a treatment modality for people that have mild depression. This is for severe depression.
So the studies will say, it's based on insurance really, or what a person can afford, but the studies will say if you failed 2 or more, then you're a candidate. But insurance companies do require sometimes, in order to pay for it, that they have trialed more than 4, have been through 6 months of cognitive behavioral therapy or some other modality. And so the insurance companies do say that these people need to be more severe than what, as clinicians, we know a person might be appropriate for. So if a person has had a lot of negative symptoms from side effects, I will say, from medications, that would be a great candidate, because if they know they just can't tolerate the medications, but they don't really have severe depression that's causing them to, not be able to work or get out of bed, that's a great person because it doesn't have the systemic side effects that medication can have.
What do you do when you find an individual who has both depression and anxiety? Because sometimes the treatments are in juxtaposition with one another. How does that work?
In regards to TMS or medication, or
just in general? We'll start with that, and then we can get back to TMS.
Right.
Obviously, anxiety is one end of the spectrum, depression is the other end, but you can have both. How does one treat both at the same time, or do you not?
And in fact, more often than not, in my practice, in a psychiatric practice, people are experiencing some of both. The antidepressants that I referred to earlier are the medications that work on serotonin. And in fact, many people don't know that the majority of those medications are also FDA approved to treat anxiety disorders.
Okay.
And so oftentimes we will look for a medication that kind of hits many birds with one stone. So if a person comes in and they have generalized anxiety disorder and major depressive disorder and OCD, we look at a medication that we know has been studied and has been shown to have positive results in treating all three of those if one exists.
So when you think about the candidates that are experiencing these symptoms, why is it that consistency is so important in treatment? You know, some people would like to, have a magic response that eliminates the problem. But these treatment modalities are not short term, correct?
Correct. So oftentimes people will say to me, do I have to be on this medicine the rest of my life? And I will say, what the studies show is that if you take this medication now, you reach remission of symptoms. And let's say this is your first episode of depression. You've never struggled with it before. There's a 50% chance after going off the medication that you may suffer from that again, that you may have another episode of depression. But one thing that really helps my patients kind of understand this is that I tell them, maybe if you lived in a bubble and life never changed and never threw you any curveballs and you never had any stressors, those external forces that play a role in how our brain chemistry works, maybe you wouldn't have to go back on medicine. But chances are, as life unfolds, some of us are just genetically more predisposed to those external forces causing those chemical changes, those electrical changes in our brain that result in depression, anxiety, panic disorder, etc.
One of the things that's interesting to me is that there are 16 million Americans that are affected by depression, and it is the leading cause of disability for those between the ages of 15 and 44. Why does it affect the younger half of the population more than the older half?
I wonder about that research, and I wonder about the generational kind of differences about, maybe in 40 years from now, we won't see those same numbers, because I do think that same kind of conception about what depression really is, and how many of our older adults are seeking care for mental health problems. There's a misconception, I would say, that can exist in our older population based on the generations they came from and what that really meant to have depression. I think people in the 50s, that was associated with things like going to mental hospitals and things like that. But really, and really that still exists now. When people ask me about my job, I'd say, I really see normal people all day long. I see normal people going through difficult times. And I think that that's just a progression in our conception of about what really is mental health care, what role does it play in our health overall, and why shouldn't we treat that and get help for that the same way we do the rest of our body.
It's interesting to me that, and we've had this conversation with many other people over the past 2 years that we've been doing this show. It's interesting to me that we are very quick to treat and diagnose illnesses of the body. Yet the brain and our mental health have come last, when it would seem to be from just from purely an anatomy exercise, that it would be top-down design.
Mm-hmm.
Why has it been reversed? Why is this the last stop on the train?
I wish I had an answer to that. I have always
Would
said,
you agree with that statement?
I would 100% agree with that. Yeah. And I think even in medical school and conceptions about going into psychiatry and that not being real medicine, I can think back to, what lecture in medical school made me become a physician. And it was an opportunity to learn more about psychiatry. And because I never skipped any classes, and because I felt bad because 75% of the rest of the class left the lecture because everyone said, and this wasn't that long ago, they were like, oh, that's psychiatry. I'd never do that. That's not real medicine. I somehow along the way, the brain wasn't, I don't think, always connected with mental health. Like, that came from somewhere else, but the brain is where the mental health comes from. And of course it's connected to everything else. And so I think now, as we're starting to progress and in medicine and ideologies about, health, I think that we will, and I'm hopeful that we will see some changes coming forward in that way.
Do you think it starts with conversation?
Absolutely.
I mean, I'm not just talking about medical conversation. I'm talking about general public conversation.
Absolutely, absolutely, I do, and I think I think people recognizing what kind of an impact uh, obtaining health from a mental perspective can have on a person's life. Really sitting with somebody who's gone through mental health problems, and then seeing them on the other side, and seeing the color and the brightness return to their face. It's hard for me to imagine that no one would think of that as part of health, because I've seen my patients look different. I can see them from the time I look at them in the waiting room, that they're dressed and they have life. And that's the best reward, because, I know that that a lot of other physicians have something tangible they can feel, they can look at, they can see. And this is a lot more in the gray zone, but as a psychiatrist, I can see it as plain as day.
So at what point does the conversational therapy enter the treatment modality?
So really for me, it might be different than other clinicians, but for me, it's day one. So people come into my office, and in the first hour will say like, "Oh my gosh, I can't believe I'm going to tell you this. Like, I've never told anybody this." And so just being that listening ear for somebody to be able to feel like they're in a unbiased location and place, to be able to just talk about the things that they haven't been able to get off their chest, starts that talk therapy, if you will, and allows them to feel comfortable with somebody that they are going to be able to kind of just divulge everything to.
In what capacity will you treat someone who you recognize as having suicidal ideation or simply being suicidal? What happens when somebody is at that point?
Yeah, that's a really good question. So I think one thing that people expect might happen if they go into a psychiatrist's office and express that they're having suicidal thoughts is that I might send them to the emergency room right away. In fact, it is the necessary step for a lot of patients, but I will tell you that many of my patients experience suicidal thoughts. It is much more a part of their life with mental health problems than I would like it to be. And so I will tell people, people talk to me about suicide all day long, and I don't hospitalize people all day long. We start looking at what are the risk factors and what are the protective factors for a person who is having suicidal thoughts. And where are they on that spectrum? Do they have things to live for? Do they have a support structure? Have they gone through a lot of losses recently? Are you hearing anything hopeful from them? And we really kind of just ask them all those questions, and say, do you feel like you have anything left to live for? And when we're starting to get the sense that there's a lot of hopelessness, that there really isn't anything that we could do in this moment here and now to change that risk, that's when we say, I think we're looking at a higher level of care. Sometimes that's hospitalization, and sometimes that's something called intensive outpatient hospitalization. Or partial hospitalization, in which a person maybe they really have no intention on killing themselves, but the thoughts are just there. They're present a lot. They don't want them to be there. They want them to be gone. They have some support structures, but they're really starting, their functional status is really starting to decline. Those are people that will go into a partial hospitalization, which they will get to go home at the end of the day. They spend several hours doing therapeutic modalities, talk therapy, meeting with psychiatrists, group therapy, individual therapy, and that happens over the course of 6 to 8 weeks. And really, that is one of the most therapeutic things that we have for a person in that moment. Because a lot of times when a person's hospitalized, they feel their rights are taken away. They're there against their will. They feel like it could make things worse. And for some patients, it in fact could. And so we really need to be thoughtful about not just being trigger happy with sending somebody to the hospital if they're suicidal, but at the same time, if we send someone to the hospital, it's because we mean it, and we really think that that is a huge risk at that point. And I think it's important for my patients to know, like, I don't do this all the time. And I will say to them, how many times have we talked about suicide in this office? And I've never sent you to the hospital before. So today is a special day for me. Like, if I'm worried about you, something's different. And generally people can respect that.
Absolutely. Today we've been talking with Dr. Johanna Wilson, who is a psychiatrist here in Mansfield, Ohio, a proud alumni of the Ohio State University. That makes us happy. And the very first provider to bring in a modality called transcranial magnetic stimulation. The first step obviously would be to schedule an appointment to see you. You
Yes.
are accepting new patients?
We are accepting new patients, yes.
So how does somebody find you?
Perfect. So the easiest way is to go to our website, which is www.hope419.com.
Hope 419.
Yes, Hope 419. And there's a book online section. And right at the top of that page, there is a new patient and referring clinic option. So one important thing to note about TMS is that you do not have to be a current patient of ours. If you have a treating physician, a psychiatrist, a good patient physician relationship, but you're interested in TMS as a modality of treatment, you can be referred to us just for TMS and continue your relationship with your outpatient provider, whether that be primary care doctor, or et cetera. But we're always accepting new patients and are glad to be helpful to the members of Richland County. And
so once again, hope419.com, hope419.com, hope419.com. We always say it 3 times. Because we find if we say it 3 times, then maybe you might remember it. I'm Jay Fox. This has been Coffee Talk. We're a service of WMFD TV News and available on WMFD.com, sponsored in part by the Cove Coffee Shop and the new Cove Pizza Shop. Absolutely delicious pizza in downtown Old Town, Ontario, Ohio. Johanna Wilson has been our guest. Thank you, doctor. And we invite you to stick around and listen and watch more, because there's more exciting stuff coming your way in the month of April right here on WMFD. This has been Coffee Talk. I'm Jay Fox. Thanks so much for watching.